the theme of our call is surviving in the times of COVID-19. And as you know, all of us are currently going through a tough situation globally. So people have a lot of questions, about how Corona started, what are the symptoms, what is the new normal, and whatnot. And to help us get answers to these questions, we have Dr. Nandita Divekar and Dr. Mukul Acharya from UK with us here. Before we get into the questions, let me just introduce them. So we've got Dr. Nandita Divekar. She's a consultant in anesthetics with a special interest in critical care, and she's based in the UK. Good evening, Dr. Nandita. Over to you.
Good evening. Namaste, everyone. Greetings from the UK. Thank you, Akshay and Shweta, for inviting me to share my experience during these unprecedented times. I'm from Mumbai, born and brought up in Tardev, studied at St. Columba High School, then Xavier's College for 11th and 12th, Lokmanya Tilak Municipal Medical College, Sion Hospital. And I came to the UK in 1988 with my husband. It has been a really long journey. I did all my anesthetic and intensive care training in the UK for 8 years, following which I was appointed as a consultant. And I work as an anaesthetist, that is putting patients to sleep. About 30% of my work is in critical care. So patients who require more care than a normal ward. In UK, remember, mainly everything is NHS. Everyone who's a UK citizen is entitled to free medical care, whatever their status. And private hospitals don't have as much intensive care facilities. In this talk, I'll be sharing my experiences and no confidential data revealed or no political controversies. I must thank all my colleagues here in my hospital, my staff, my trainees, the management who has been really fantastic during this pandemic. Yeah, thank you very much.
Thank you, Dr. Nandita. It's definitely an honor to have you on this call with us. All right, we now move on to introducing Dr. Mukul Acharya. So Dr. Mukul is an ENT surgeon, a microbiologist and a virologist in the UK, again based in the UK. Dr. Mukul, it's an honor again to have you on our call. Over to you.
Hi everybody. Hi Nandita, Akshay and Shweta. Thank you very much, for inviting me to this, forum of yours. And I believe you're doing a grand job, trying to reach out to people, and I did sort of, speak to you earlier and read about your, the service which you're offering, and that's really commendable. Me and Nandita obviously have known each other, as colleagues, batchmates from medical schools in a long time, and as you know, she's a very sort of prominent, consultant, intensivist, anesthetist, and we're sort of quite privileged to have her here on the forum today. A bit about me. I used to be an ENT, or I'm basically an ENT surgeon. That's how I started my career. Trained in Mumbai. I'm originally from Mumbai. Was in Lokmanya Tilak Medical College. Finished my training. Then I was a lecturer there for a few years, and before then I decided to sort of move to fresher sort of grounds, which I thought was a great move then. But anyway, here I am. And then I obviously trained in ENT, and then I decided to diversify because of my interest in infection prevention, microbiology, virology. So I sort of, did another training, and now currently I'm working as a consultant microbiologist, virologist, with obviously a special interest in infection prevention. And that's how I guess we are all here now.
Yeah.
with the current situation, which obviously none of us really expected.
So. Thank you for your
let you take over.
Introduction. Yes, I think so I think let's get started. So Dr. Mukul, can you throw some light on COVID-19, as in when did it all start? When did the first cases start coming in? What were your thoughts then? Before the cases started coming, if you could just tell us about it.
Okay, I mean, it's interesting. I'll just give a brief background about what COVID-19 is. So COVID-19, as you all know, everyone knows now. It's coronavirus disease 2019. That's what the 19 starts for. Now, coronaviruses are known to have caused infection in human beings since ages, probably more than 500,000 years ago, and most of these coronaviruses usually cause only things like common cold, a bit of upper respiratory tract infections, as you would call it. But then these are, RNA viruses. So there are two types of viruses. So one is the DNA and the RNA. The DNA viruses are one like hepatitis B, smallpox virus, and some other groups. They are very stable viruses, while most of the RNA viruses, as a rule, are actually unstable and therefore very prone to mutation. And call it nature's sort of way of dealing with all the pollution and the uncertain things happening on this place. It's coronavirus tend to mutate. We've already seen that in 2003 when we had the first SARS outbreak, which was the severe acute respiratory syndrome affecting the Southeast Asia. And then it came back a second time in 2012, which was the MERS coronavirus, as they call it, or the Middle East respiratory syndrome. And then it mutated again. So now the mutation is a 1 in a million chance, because for the virus to mutate, change its genetic structure so that it can infect, the animal kingdom or the birds, is a 1 in a million mutation. And then it has to undergo another mutation to become transmissible from the animal or the birds to human beings. And for some reason, this seems to have taken place, possibly sometimes last year, a third time, when this virus jumped from the animal kingdom, say call it bats or snakes, a lot of theories, which will eventually reach the bottom of at some point, and then jump to the humans. And then what is more important is transmission of human to humans. And that is what makes a difference. If a virus jumps from animal kingdom to humans, that's fine. Humans who are in close contact with the animals would get infected. And depending on how severe the infection is, that would run its own course. But in this case, the problem is when it starts transmitting from human to humans. That is when it will threaten to become an epidemic, or if it's highly transmissible, then a pandemic. And that is what we have seen currently. So coronavirus disease probably started sometime in 2019 is what the theories are, somewhere in China, obviously, and we all know what province.
Right.
And then when people realized what it was, it slowly started obviously migrating. And thanks to global travel, it's very easy. You see, we have had lots of pandemics. We've had the plague, we've had the flu pandemic, in the 18th century, 19th century, First World War. The death toll then was probably more because there was not much concept of infection prevention and control. Now, we obviously, all of us know the importance of infection prevention control, but the death toll is more because of the easy transmissibility. The virus just has to jump on a flight.
Correct.
Obviously in a human host.
Right.
It just goes transcontinental. And that's probably what happens. And then it depends how how potent the virus is and what is its transmissibility. In the case of coronary virus 19 disease, which will obviously will come later and talk about symptom signs, which Dr. Nandita would throw more light. But what is important is this is not as potent as SARS or MERS coronavirus, but it is the transmissibility, which is becoming an extremely important factor.
Right.
We are fortunate that the SARS and MERS coronavirus were not highly transmissible. So their mortality rate was much higher.
Higher, right.
So that is probably what is happening.
Thank you for sharing these details and explaining it to us in in layman terms. It definitely helps understand how it all started.
But I'm sure everyone is sort of reading so much on the net that you probably understand a lot of medical terms as much as we do. So
correct. Right. And so I think people would also want to understand how. So I think you said, but in terms of spreading, there are some misconceptions that people have. So would there be any message for people that will help them overcome those misconceptions?
So as far as spread and transmission is concerned, I mean, let us. This is a virus which essentially affects the respiratory tract. So the mode of entry is through the nose, and the rest of the respiratory passage and the mouth, and then it will descend down, and then depending on the immunity of the patient, it will decide whether it just dies a very asymptomatic, uneventful course, or it becomes quite morbid. How does it transmit? So it is actually not an airborne transmission as you would expect with something like anthrax. Anthrax is a much more severe, and therefore it is used in bioterrorism, which the spores just float in the air, but not this. But this is a droplet transmission, which means the respiratory droplets, which obviously are thrown out of a particular patient in the form of coughing or sneezing, they would then settle on the surroundings, on the atmosphere, and the virus is known to stay viable. And when a second patient would touch them accidentally, and with lack of hand hygiene, when it touches the nose or the mouth of that person, then the virus would enter the next person. Okay. So the transmission is a droplet transmission. Right. But I mean, it's not airborne, because it's not that you talk and the virus comes out and it just floats and goes into the nose of the patient opposite. But if you were in the line of fire, which means in a direct line of a cough or a sneeze, because when someone coughs, it's about a feet or two. Someone sneezes, it's long distance. So if your face is in the line of fire, then yes, you can. So the sneeze is something which comes out, quite powerfully with a velocity. Hence, but otherwise, it's not an airborne transmission. It is a droplet transmission. Therefore, you have to be very careful with your hand hygiene, because it stays viable on plastics and other external metals for almost a day or 2 days. On sort of copper, it would stay only for 5 or 6 hours. Copper has its own properties. Right. And on card paper, it probably stays for about 12 to 18 hours. Okay. So what is important for people is, when you go out, when you are touching things, you have to wash your hands, sanitize them, and do not touch the hands to your nose and mouth. That's all you need to follow. Nothing else. Very simple.
Yeah. Thank you. I think that definitely helps us, clear some misconceptions. So yeah, now that we know how it spreads, let's hear it from Dr. Nandita on understanding as to who are the most vulnerable to COVID-19. Dr. Nandita, over to you.
There have been a lot of studies actually during the COVID-19 era, and we found that males are 3 times more affected than females. Okay. Older age group have a higher risk factor for infection and severity of the disease. Though the rate of infection in 40 to 64-year-old age group was found to be higher, the number of deaths in a study in US, it showed that number of deaths were much higher in those people who were more than 65 years of age. And over 80 years of age have really worse outcome. Have you heard of the term BAME, which is Black Asian Minority Ethnic? This population has been shown to be disproportionately affected. Now, okay. In UK, 21% of our staff members are BAME in healthcare, and 63% of the healthcare workers who died were from the BAME population. Okay. Also, 44% of the medical staff are BAME, and 95% of the doctors who died were from the BAME population. You can say, and in India, everybody is BAME, right? Because we are Asian, so there you go. And then you've got diabetics, poorly controlled diabetics. The diabetics are more prone to have COVID, and the mortality rate is higher. Obesity has been shown to be a factor. In patients suffering from cancer, the reason being they are on chemotherapy or immunosuppressant drugs. So the immunity is suppressed, so they are more likely to get it. As well as chronic kidney disease, chronic liver disease,
Right.
patients who've had organ transplants because they are on immunosuppressant drugs, patients who are hypertensive. And the other factor important is travel to a place with high community transmission and close contact with a person who has got this sort of respiratory illness. Care homes have shown a higher incidence as well.
Okay.
And lower socioeconomic strata. So in deprived areas, the incidence is higher. They say in cold climates as well, but there's very weak evidence. So these are mainly the groups who have been affected.
Yeah, I think that thanks for talking about which were the groups that were the most impacted, and what age group is the most vulnerable.
That's right. That doesn't mean that all the other age groups have to take it easy. We have to also follow the social distancing, whatever has been told to us.
Yes.
So that's very important. And Dr. Acharya will concur with me on this, that we have all to be very careful because we are young patients as well.
Yes. Thank you for adding that, because that definitely gives us a perspective there. Yeah, so I think now again we go back to you, Dr. Mukul, to understand what are some of the symptoms and signs in critically ill patients.
This is interesting now, and therefore this is all the talk about how to prevent transmission, and why does it transmission, and why is it spreading with an exponential growth. So the thing is, almost 70 to 80% of the patients who are exposed to this virus and who catch this virus tend to be asymptomatic or have very mild symptoms. So which means it's someone who's healthy, young, fit, and has no comorbidities or medical conditions. And if he or she was to be exposed to the virus, would usually have almost no symptoms or very mild illness. So they would be blissfully ignorant that they've actually had it. Then you've got the next group who would experience some form of symptoms. Now, what are the classical symptoms? I mean, this is essentially, to start with, a respiratory ailment. So the symptoms which you would experience is very mild sort of, cough, dry cough, sometimes associated with sore throat, with or without fever. The fever can be high grade, 38.5, 39, in centigrade, or if you were to measure in Fahrenheit, almost 101, 102 degree Fahrenheit, as they would in India. Then, interestingly, body ache, muscle ache, and the patients who we have seen have complained of absolutely massive body ache, as if they have been like ill or hospitalized for weeks and weeks together. They've had problems, difficulty sort of getting up from bed, moving around in the house. So yes, some of them now, contrary to popular belief, breathlessness is not common. Is not seen. Even so, we've excluded the 70% of the affected. Then we divided into the remaining 30%. Let's say the 15%. Again, they would have symptoms, but breathlessness is not common, and that is where what as Nandita would tell us is the reason why sometimes it's too late when patients reach the hospital. So we'll come back to that in a moment. But this is the respiratory system, so it would mimic any viral illness, including flu or influenza. The other symptoms which we have come across are cardiac symptoms. Patients may not have any respiratory symptoms. They may just have palpitations, discomfort in the chest, uneasiness, chest pain mimicking a myocardial infarction. Pain radiating to the left arm, to the shoulder, to the back. We've seen them. And they may have what they call as palpitations, or very rapidly beating heart. We've seen patients with sort of, who've come with just cardiac symptoms. Some patients have experienced diarrhea, gastrointestinal symptoms, because the virus is known to be shedded by these patients in their stools as well.
Okay.
So, and then the thing with breathlessness is the patient does not feel that they are having difficulty with respiration. but is their oxygen carrying capacity of the hemoglobin, which is reduced. So the only thing that would give away is a pulse oximeter, which means trying, you've got the finger, the small instrument gadget which goes on your finger.
Correct.
It tells you what the oxygen saturation is. And you'll be surprised, patients who are absolutely healthy sat down, not feeling breathless, with a reduced oxygen carrying capacity. So one word of, which we would suggest and which we have suggested to people here is people in the vulnerable group, which Dr. Nandita already said, elderly patients, patients with respiratory comorbidities, patients with cardiac ailments and diabetes should carry a pulse oximeter at home. A simple measurement of oxygen saturations is good enough. If it is below a certain level, in which case I would say the cutoff point is like below 94 or 93, you have to start thinking. Of course, someone who's already an asthmatic or has got a chronic obstructive lung disease would anyway have a low saturation.
Right.
So they would then obviously have to look at their saturation depending on what normal is for them. But these are the sort of various ailments that we've seen. And the reason is it doesn't attack the lung, doesn't attack the kidneys or the heart. It actually attacks the blood vessels supplying those organs. And that is the reason why you get this picture. I mean, obviously, Dr. Nandita will tell you about that in more detail, with the management experience.
Right. Yeah, but this is quite insightful. Like for someone, yeah.
Oh yes,
okay.
I'm glad.
Okay.
But
okay.
I don't know how many people would be able to have it. I don't know how many people here have it. Yes, chronic respiratory disease and chronic heart disease also makes you quite predisposed to COVID infection. So they come in the WHO list as well for shielding. So this is how it is. So yeah, it shows your saturation. And my heart rate is a bit higher now because I'm giving a talk.
Thank you. I think that's quite useful, and I think obviously people who will listen to this video, go through this video, obviously they'll find it useful that it's recommended to have oximeter, especially for people who fall under the vulnerable.
Correct. Absolutely right.
All right.
Can I just add one more point to that? People who presented to us because they were quite unwell. They started becoming breathless and their oxygen levels were dropping. And so, because they are critically unwell, isn't it? I come in the critical care situation. So they were worsening, and that's why they needed to come to us.
From here, Dr. Nandita, could you give us some insights as to were you all able to have any kind of pre-planning before this pandemic actually reached the scale that it and became a pandemic? Was there anything you all did do?
Yes, certainly, because our cases started coming around mid-March. And the cases started coming and then gradually increasing. Peak was around end of first week to second week of April, and it continued towards the end of April, and then slowly started coming down in May, and May it slowly started coming down. Planning was very difficult because we were very uncertain about how the virus would behave. I used to ring up Mukul as well regularly saying, oh, when is it going to come? Is it going to come? So everybody used to discuss, is it going to affect the UK badly? We had heard about China. We had heard about how Singapore manages well. And then when it came to Italy, we knew it's coming westwards now. We are going to be affected. Even before that, and we are actually planning before that. Is it going to be a pandemic? People were scared because we didn't have enough knowledge about the virus. We're still learning about the virus. And when are we going to get it? So information for the staff kept asking us, would there be a lockdown or not? So that was the uncertainty. But what was happening is, how many patients are we going to get? So we had to increase the capacity for our intensive care beds. How do you increase the capacity? And in that case, our OT, our operating theaters, the next to intensive care, we had planned if we needed to expand, all the theaters would be converted into intensive care beds. Then there is a recovery room where you send all the patients who come after the operation to recover initially. So that also would be converted into beds for these patients because they will all be ventilated. So that was an important factor. Most of them will be ventilated. Then staff, because the nursing staff in intensive care look after 1:1 nursing. So we had to probably go to 1:3 or 1:4. So we need to expand the capacity of the beds to around 50 beds or more.
Right.
And how do we do that? And also, we would have to stop operating on the normal patients, the normal operating lists, and continue emergency operating. Remember that we would have to have a space for the non-COVID patients as well.
Right.
Plan for more equipment. So how do we get it? Because everywhere ventilators were short. So we had, whether to use anesthetic machines as our ventilators, and also drugs, means whatever we would require, as well as other pumps. And we had to start getting ready equipment and make sure that we were putting it in the various theaters. So in case we had to convert it last moment, we would be able to do so. Again, staff planning for medical people.
Right.
Doctors, senior doctors, junior doctors, we had to have different shift pattern. And so we had long shifts and then night shifts, on days, off days.
Oh my God.
What happens if doctors go sick? What happens if nurses go sick? Will we have enough PPE? What sort of PPE will we be having? So everything was actually a jigsaw, and we got it. We got it well together. Hats off to our team. We worked as a team so we could get things together well. So yes, there was a lot of planning involved, and we were getting guidance from Department of Health or the intensive care medicine societies and all that. We were getting, and we were learning a lot from Italy as well. So that was handy for us.
Right. Thank you so much, because that brings me to my next question. Where you mentioned the PPE, so we really wanted to know what it is like managing with the PPE. What were the challenges you faced? How do you go about it? How did you?
So PPE, we have been very lucky in our hospital that our procurement gave us very good PPE, and we were not short. So in our intensive care, we were never short of PPE. And it is very difficult to gain that concept. We had to do mask fitting testing first, and we had to check whether there were any leaks. And different types of masks were there. So some masks, you have to check whether there are leaks any first. Then we were taught there was protocols and simulation possibly to how to don and doff. Don means wearing the PPE and then taking off. So you wear a theater cap, then you wear the mask, see whether there is any leak. Then you wear the hazmat suits or the gowns. The hazmat suits are the ones I've sent pictures here, which are actually fully covered. So that made me feel really safe. Some of them are used in nuclear plants. So you can imagine that how safe it would be.
Oh, wow. Okay.
So you wear that, and then you wear double pair of gloves, and then you wear the visor. You have to train for it. And then you go in. The main challenges were it's unfamiliar. It is very, very hot. Very hot inside. Once you go, though you might be in air conditioned space, you'll feel really sweaty. Then you're wearing the masks. The mask, if you change position, can sometimes leak. You're trying your best so you can put additional tape to your cheeks and all, which, when you take it out, it might start bruising. Cover yourself with a visor. So when you're covering yourself with a visor and you have a mask, there have been studies that the carbon dioxide levels go on increasing. And therefore you tend to get headaches. And also you've got other things like dehydration, because once you're in, if you have to come out, that means you have to take out the whole PP and throw it away. So you can't come out very quickly. You have to stay there. And there are patients who are really, really unwell. Of course, if you need to, you can come out. But you will be wasting another PPE. So you have to think of those things. And so the longer you stay, the more dehydrated people used to get. Naturally, they're very thirsty. Again, going to the loo sometimes, you have to be very careful. You have to go to the loo first, but you have to drink enough as well. So going to the toilet was a problem. The other problem was you could not hear what people said, and other people could not hear you. So can you imagine when you go to the patient, if the patient is awake and if you have to put the patient to sleep before coming to the intensive care, they used to go like aliens, Star Wars people, isn't it? And nobody can, the patient can't see you or can't hear you. You have to literally shout and in that condition. So it is difficult. Again, if they can't see you, the nurses couldn't see you either. So we used
Right.
to actually write our names down saying, oh, Nandita, and so on. So these were our big challenges. And again, you can't touch your mouth. You can't touch to adjust things. If it's hurting you also, you can't actually touch your mask because that is the most dangerous place you have to touch. So we can't touch it. We have to, just be like that. So it was difficult to get used to it, but gradually we got used to it. And I actually felt safe in the hazmat suits myself, I should say, as compared to, not wearing or wearing less. So I did wear my full PPE and enjoyed wearing my PPE because I wanted to be safe for everyone. So those were the challenges, and
Wow.
we done well as a team. We did well. We got trained, and we had to doff. Doff is taking out the PPE and
Right.
then disposing it off, coming out, washing your hands again, gelling your hands, and then taking out the mask without touching your mouth, again washing your hands. So these were the real challenges we had, but we did all right.
Right.
Thank you for sharing that. Yeah, I mean, it really hats off to you and your team. You can't even imagine, what you guys must have gone through, and obviously,
Yeah,
I think
but worldwide, I think they have done very well, and
Yeah.
PPE, yeah.
Yeah, I think definitely. I think it's
Absolutely.
like
It was phenomenal.
it is. It's like warriors, right, on the battlefield.
Absolutely.
But say at least on the battlefield, you know where the enemy is hiding. In this case, you don't even know where the enemy is, right? It's an invisible enemy, right? So I think great job there. Yeah, I mean, really a lot of respect for all the doctors and the entire medical staff. So I think that brings me to our next question. For you, Dr. Mukul,
Yeah.
So talking of all of this, how did you all plan for investigation and all the tests? How did you go about it?
Right, that's interesting. So, as Dr. Nandita already said, it was on the shores of UK. It probably did enter UK somewhere, sometimes in mid-February, is what we feel. But obviously, we were not very aware. We knew it had come to our neighboring countries. We had seen Italy. We had seen what is happening in Spain was, gradually going up. People were still not sort of, they weren't very certain how significant or how severe the disease is. But once we started getting people with symptoms, we realized then the moment, so the most important thing was how to diagnose. So obviously we had to wait for the WHO guidelines and we had to wait for tests to be validated. So there were a lot of companies which were bringing out kits for doing the test. But we obviously had to make sure that they were working well, that they had a positive and a negative control. And then we had to validate and then roll it out, to be tested for patients all across. So this is a job of the infection prevention control team. In UK it is done by the Public Health England, and then we obviously are part of the infection prevention control team. So our job is not only to investigate, but we also have to write guidelines for what to wear, what not to wear. So the PPE, which Dr. Nandita referred, is personal protective equipment. Just for the people to understand.
Yeah.
So personal protective equipment is something which will obviously try and prevent a patient or an individual from being exposed to the disease. And this is the guidelines which we had to write. And we had to keep looking at the recent advances, keep looking at the WHO guidelines, at those other countries which were more involved or had already experienced that, and then keep changing. So we really had to look at the guidelines, and our guidelines would probably change every third or every fourth day because we weren't really sure what was happening. So now, because this is a virus, as you understand, if it is a bacterial infection, it is easier to diagnose that because a lot of bacteria would grow nicely in various culture medium, just as they grow very nicely in the body, in blood or urine, bacteria can grow on artificial cultural mediums, which when you have proteins and other nutrients incorporated, and they are seen under the microscope on a gram stain. Unlike viruses don't grow very easily in cell culture lines, and viruses need electron microscopy, which obviously is not available. So what people have devised, people are clever. So for viruses to be diagnosed, we actually look at the DNA or the RNA particles. So therefore, I was talking about DNA and RNA viruses.
Correct.
So what we do is molecular-based tests, which are called as PCR, polymerase chain reaction, which essentially means you have to basically extract the RNA or the DNA from that virus, amplify that so that the number is big enough. There are enough number of copies, and then they are basically then sort of subjected to some sort of reaction, which could be an immunofluorescent reaction or some special staining, or some sort of electrophoresis or chemical fluorescent reaction, which will diagnose the RNA or the DNA. So these are the PCR tests. So the moment we had the PCR test, it had to be rolled out to various centers because the kits were being utilized at a much more rapid pace than they were being produced by the manufacturing companies. So they had to be first rolled out to referral or centers which had the virology lab, which would then cater to X number of hospitals in the region. You see, in UK, everything is National Health Service. So all the hospitals are government hospitals. And every region has got a central hospital with sort of, like a tertiary care hospital with a central lab. And then they have got a few district general hospitals around them, satellite hospitals, which are again big enough, but obviously they wouldn't have the virology facility immediately. So initially, it was very difficult for us. Initially, we thought that we should, the moment there was a patient who was symptomatic arrived in the A&E, the accident emergency or the emergency department, obviously people would be wearing the protective equipment and then doing the test. But then we realized we are soon running out of kits. So then we had to prioritize and we had to triage. So the thing was, then we said to ourselves, if we do a test for a patient who's got mild symptoms and we say the patient is positive, say, let's assume, we're not going to admit the patient in the hospital and treat the patient. What is required is the patient needs to be quarantined or isolated at home. So then we had to triage. So then, and this is what every country has done. So only those patients who need hospitalization would be tested. And anyone else with symptoms would be isolated. Simple. So the plan is, it's a very old thing that prevention is better than actual treatment.
Right.
And that is what we're trying to do. So infection prevention and control, IPC, and then management if it comes to management.
Right.
So we would do the test if every country had the access to in a sort of endless number of kits, we would test every patient in the community, but that's not feasible.
Correct.
That is not feasible because this was unprecedented. We did not know what the numbers would be like. So then we had to prioritize, decide who to test. So all those patients who came to the hospital with respiratory difficulty, breathing problems, or severe cardiac conditions were the one who would be admitted, who would be tested, isolated. So just as Dr. Nandita said, they had their sort of, intensive care unit, with extra beds. We had our wards divided into COVID wards, red wards. So red wards were the one which had active COVID-19 infected patients. Then we had purple wards or purple zones, where those are the patients with suspected symptoms of COVID-19 awaiting results of test. And then we had a green zone, where those were the non-COVID-19 patients who had no symptoms and who were unlikely to be COVID-19 patients. And this is important because the PPE which you wear would be different in different zones. Okay, so as we already said, this is not an airborne transmission, but if patient can cough, patient can sneeze, and hence that amounts to airborne transmission. So all those patients who are COVID-19 and who are going to require aerosol generating procedures, so where they're going to cough or sneeze or anything to do with the respiratory tract secretions, are the one who are going to need the maximum protection, which means they're going to need what Dr. Nandita said, special masks with a filter, which would filter out, the smallest particle in the smallest virion, almost ranging to less than whatever 3 microns or 1 micron. So these are the special types of masks with filters. And then obviously you need to have visor and the entire gown and all that. Those patients who are COVID-19 but who don't require respiratory intervention, the staff would then wear surgical mask, gloves, and a disposable apron or a plastic apron. So the level of protection depends on the type of patients and the type of infection that you have. So once we knew that we were doing, then we started getting kits and we started doing the PCR test. So there are different type of machines of platforms available. So there are some platforms where everything is automated, where the extraction, amplification, everything is done at one go, and it still takes about 3 hours. So we do a batch of 30 to 35 tests, and we get the results. And then you do about 3 or 4 runs during the day. And there are some platforms, and if you have those kits available, where you can do 100 tests in one run. So it's about 3 hours and 100 tests and 100 results. And then we could do 4 runs. So we could do like 400 tests in a day. Yeah. So these were the PCR tests, which we sort of started doing. And then based upon that, we could segregate people and what we call as cohort, which means those with the same symptom, same disease are in the same ward or the same area. So that's cohort. And then only a specific set of nursing care would tend to those infected patients. Those nurses or those healthcare workers will not then look after the non-COVID patient. So that's called cohort nursing.
Okay.
So you have to cohort patients and you have to cohort the staff. And we had to go to different wards and make sure that they were. So we were not wearing the hazmat suits, because we were not involved in the direct respiratory care or intubating or putting patients on ventilators. But we still had to sort of go and see the patients, and we had to wear and go from different wards, sometimes not knowing who's infected and who's not.
Wow.
But that is about the molecular test.
Right. Oh, wow. I mean, that's quite. I mean, I've got no words to express as to what you all must have gone through. But that was definitely useful. Now again, talking of testing, so people have been talking a lot about antibody testing. So if you could just share your perspective on antibody tests.
Absolutely. Yeah, so what we talked about, the molecular test or the PCR test would look at the actual RNA or the DNA particle. So the actual infecting material, or what we call as antigen.
Right.
Now, when a body is exposed to an antigen or infecting particle or organism, antigen in microbiology terms, the body produces its immune response, its own sort of set of soldiers to fight the infection. These are called as antibodies. So the antibodies are produced by the body's own system to try and fight off the viruses or the bacteria without requiring, any antivirus or antibacterial. So normally that is what a body does. It fights off the infection. So there are various types of antibodies, which are produced. We won't go into the details, but we'll just talk about those relevant ones. So there are 2 main types, which people, would probably know. So the first set of antibodies which are produced as a response to infection to a foreign antigen detected by the body are called antibodies G, or Ig immunoglobulin G. G for golf. So IgG, I beg your pardon, it's IgM, or M as in mother. So these are the ones which are first produced in response to the virus or the bacteria. And they would try and fight off the bacterial viruses. Then their levels would start falling. And the body has now acquired that antigen and kept in its memory. So that goes into the memory cells of the immune system. And then as a response to that, it produces special antibodies called the IgG, G for golf, which means these are the antibodies which in the future would protect the body from any infection from that same type of antigen, the same type of virus or bacteria. So the moment the IgG detects a new and the same antigen in the past, it actually reignites the body to produce antibodies specific to that antigen. So the IgG is the one which would detect and give long-term protection or immunity. So these antibody tests are the one which are devised. So the antibody test, as opposed to the molecular test, is slightly different. The molecular test is a test which would collect the samples which is infected. So the respiratory sample, that is the nasal swab or the throat swab. But the antibody test is in the blood. So you have to draw out blood or serum and then look for the antibodies. Unfortunately, we still haven't got the separate IgG and IgM antibodies. You see, when you have, because it's still being validated all over the world. So if you were to differentiate between the IgG and the IgM antibodies of a person, so if a person tests positive for IgM but is negative for IgG, it means the patient has just had a recent infection, because only the IgM are being produced. So that's a recent phase of infection. Once the active phase is over, the IgM would drop and the IgG would then start to appear, because then the memory cells, it is being stored in the memory. So if you find a patient with IgG antibody present, it means that this patient is actually now sort of, launching a protective response. So that's about the IgG and IgM. But what we have now is total antibodies. So the total antibodies means that the person has been infected at some point. Recent or old is difficult to say. But because we know that the antibody response is lodged about 7 days after the first symptom appears. So you know that the patient has had an infection which is more than 7 days. And then after about another 7 days, the patient will be protected. So a thumb rule is, if an antibody test is negative, you can safely say that after about 7 days, the patient is protected.
Okay.
So that's what we have derived. The $1 billion question is, how long is the protection going to be conferred?
Right.
And we're still trying to find out.
Okay.
It could be months, weeks, or years.
Right. Correct. And it's very difficult to also say that, you know, if the test, if a patient say tests maybe negative, say in terms of the antibodies, then people, I think there were a few people who would say, who were saying that, you know, if it is negative, then yes, this person can not
is prone to infection.
Oh, is prone to infection. Okay.
Yeah. So if someone does not have antibody positive, if his antibody is negative, it means he's prone to infection, which means he's not had the infection before.
Oh, okay. Oh, wow.
That is what it means.
Interesting.
Yeah.
Thanks for clarifying that.
Yeah, that is what it is. But if a person has had PCR test positive, it means he's definitely had the infection.
Oh, okay.
Yeah. You know, so that is the interesting thing. So, but also what we have to remember is the PCR test. If a patient has his test done or her test done and it's negative, it does not mean that they've not got infection, because there are 30 to 35% chance of this being a false negative. So if a patient has strong symptoms suggestive of COVID-19, but if the test is negative, you cannot dismiss that patient as to be not infected.
Okay.
So the moral of the story is, you still cannot lower your guard. You still have to use your personal protective equipment, do a retest. And the reason being, what it means is, a false negative, there are various reasons. Either the swab is not taken very well, it's not got enough of the infected material on that swab stick, or it also means that the viral load is low. So it could mean the patient has already had the infection and is now in a convalescent phase, or it's a very early part of the infection. So in that case, we have done repeat tests, 1 and 2 negative, and then a third time has been positive. Dr. Nandita knows so many patients have gone to the ICU, have been on ventilator, and negative tests so far, but they're clinically and based upon the CT scan picture, they know that this is COVID-19. So we still treat them as COVID-19. And then finally, when we draw a sample, which is from the lower respiratory tract, which means we do a procedure, do a bronchoscopy, and and draw a sort of, sample from the bronchus, the windpipe, and lower down, then it's positive. So lower the sample, more is the positivity.
Okay. Wow. Thank you. Thank
so
you
it's
for.
So it's important, that by just a single negative test does not mean there is no COVID.
Right. Right.
So don't lower
Thank
your
you.
regard.
Yes. Yes. Thank you. Thank you for clarifying that. Yes. Yeah. That's true. So now I think we move slightly towards talking about what is the hygiene that people need to maintain, because obviously you must have heard there's a lot of fear globally, and
Yes.
in India, as we need house helps to help us with household chores.
Important.
So what precautions would you recommend that people need to
That's
take?
interesting. When you talk about hygiene and hand hygiene, the hand hygiene is the single most important precaution that you have to take.
Right.
So what I mean, of course, this advice what we're giving is very generic and not pertaining to any positive patient. This is just a general advice. Right. A patient who does develop symptoms will obviously have to seek help. But as a sort of thumb rule, the most important thing is now. When people go out, you cannot stay home forever. The economy has to obviously be taken care of. People have to go for work eventually. The simple thing to do is wearing a mask. Now, how does a simple surgical mask help? A simple three-ply mask, as they call it. If a patient is infected, if they're coughing or sneezing, the mask would at least prevent those particles, droplets settling anywhere else in the environment. So that would reduce the spread, the transmission. Two is, when you wear a mask, also wear gloves with that, especially if you're out in public places, because then the mask and the gloves would prevent you from touching your nose and mouth. Simple.
Right.
Just a simple preventive measure, but that is what is required. So when you come back home from the outside, you've been to a place where there have been people, an office or a shopping mall or center. You have to make sure that you have to wash your hands, basically dump your clothes away, change them, and then obviously mingle with the rest of the people. So now there are basically two questions. One is home help, means
Correct.
home care help. That's one.
Correct.
And two is sort of how to sort of protect people. So yes, this is what is happening here in the UK as well, and it's probably happening worldwide. You can have domestic help coming in to help, to do sort of the work which you would want to. But there are certain sort of precautions to be followed. The domestic help obviously has to wear a surgical mask, some form of mask, basically a cloth mask, a three-ply mask. As soon as they come in, they have to wash their hands with soap and water. And believe me, soap and water is even better than alcohol. Simple soap and water is good enough. You don't need every sort of 70% alcohol. Yeah, if you're just going to sanitize and not wash your hands, then you need 70% plus alcohol-based gel or solution. But simple soap and water is fine. They have to wear the mask, and they should avoid going to an area in the house where there are vulnerable adults or vulnerable patients. So the domestic help should not be in contact with the vulnerable adults. That's very important. And if the domestic help was going to come to people's place to work, if they have symptoms, then obviously they should not be then coming. Especially when you have vulnerable adults or vulnerable people at home. So that's important. So wearing a mask, hand hygiene, wearing gloves is the single most important thing that should be done. And when you have a domestic help at home, people at home should also be wearing surgical masks similarly, because for all you know, someone at the home may be infected or have got symptoms, and they may pass it on to the domestic help. So it works both the ways. So when you have a person who is not your family member coming to your house, both of the members will have to wear a surgical mask and hand gloves. That is the minimum that you can do. They should avoid, going to different places in the different areas in the home. As I know, sometimes it's not practical, but as far as possible, try and sort of, do things only in a given area or a single given room, and protect all the all the vulnerable members, because we do have joint families in India, we know that.
Right.
But it is very essential that they are protected completely.
Correct.
So when we discuss herd immunity in your next question,
Right.
we'll talk
Yes.
about that.
Yeah. Thank you. I think that was quite useful. So that was about the homes. Now slowly, workplaces will start calling in their employees to work from office.
Interesting.
And what precautions would you recommend for the workplaces?
Yes, that's interesting. Now again, here the concept of distancing, social distancing, is very important. So 2 meters or 6 feet minimum distancing is what they say, because that they have found is the possible airborne travel of a virus which may take place. So if you're in an office and if you're going to use your own laptop, your own sort of desk, then there should be a minimum 6 feet distance. Plus, you can actually put up barriers, transparent hard glass or plastic barriers, which on either side, and obviously you will have the wall or something in the front, so that the person who sits there is almost like working in an enclosed area, which we have in our labs. We call it CL3 or category 3 area. It's very, very simple. Just as if you go to a bank or someplace, there is always a plastic, hard plastic or a glass transparent barrier, and things are only done through that. So social distancing is very important in between the desks. So you cannot have to each other in a chair without a barrier, or they should have if it is not possible to keep 6 feet, then you should have a barrier. That's very important. People, when they move out of their place or their designated area, they have to wear masks when they move anywhere else in the office. If there is a common kitchen, which happens in a lot of offices, where you go for your tea and coffee and microwave and stuff. Not more than 2 people at the same time in any given enclosed area.
Okay.
That is very important.
Correct.
And if a third person was to enter, then every person then wears a mask.
Correct. Right.
So if it was mandatory for a third person to enter the room, then everyone should be wearing a mask. Otherwise,
Correct.
2 people can be in the same room at a distance of 6 feet, and then you don't need to wear a mask.
Right.
As long as you're not coughing on each other's face or sneezing on each other's face.
Right.
That's important.
Yeah.
So that 6 feet distance is very important. Every desk should have a sanitizer to sanitize their hands.
Right.
Yeah, that's very important.
Yeah.
And tissues which have to be binned immediately. So as they say, if you sneeze, catch it, bin it.
Correct.
As Dr. Nandita would have seen everywhere. All hospitals have got that board, catch it, bin it.
Right.
I think even in the lifts, only 2 people are allowed at one time.
Yes, valid
that is
point.
now in the hospital as well. Everybody has to wear a mask, but 2 people are allowed in the lift at one time.
Right.
And they're saying instead of face to face, if you have an open space office, you have to have back to back more than face to face. So that is one of the guidelines. The government of UK has actually produced detailed guidelines on what office should look like, or hope.
If you have face to face, you need a barrier.
Right.
Barriers in between. So just like our supermarkets now are slowly having in between, because where you're paying by card, we are having contactless cards and everything, and we are having barriers like plastic barriers in between the 2 people standing there.
Right. Thank you. That is very, very useful, and I hope workplaces follow these tips. And needless to say, of course, carpets need to be shampooed, obviously, because I think that's where again you'll find the most.
Actually, that's a very important point. In fact, there is a concept. If someone in the office was found to be having COVID-19 positive, and if he was occupying a certain area, then that has to be deep cleaned. So deep cleaned, which means using those alcohol wipes, or actually cleaning with water and soap if that is feasible. If not, then alcohol wipes. So you have to clean the entire and all those equipments which that person may be handling. Another important thing which I should have mentioned is when you are sort of in a workplace, and if you were to sneeze or cough, make sure that your mobile is away. You see, the single most equipment which can cause transmission is your mobile. That is so when you go grocery shopping, there are lots of items on the shelves, and we tend to pick that up, and everyone is going to touch that. Make sure that once you've done your grocery shopping, you are not going to ideally use your mobile. And if you have to use your mobile, sanitize your hands and then take the mobile out and then use it. Because the mobile is one equipment which really can transmit infection, because would have all your virions fomite settled on it.
Thank you.
And
Thank you
many
for
people take their
sharing that.
mobiles to the toilet as well, isn't it?
Oh yeah.
Yes.
We've had diarrhea outbreaks courtesy the mobile.
Yeah, absolutely.
Sorry, but
yeah. Thank you for sharing.
That is a fact.
That was very, very useful.
And one more question which people keep asking is whether bleach is enough to clean, to disinfect, and that everybody's evidence shows that it is enough if you clean with bleach.
Absolutely right.
Okay, Dr. Nandita, I would like to get an idea of what was life like through the pandemic at work as well as at home.
Yeah.
What was it like?
The reality was we as a hospital were very, very busy. We were one of the busiest hospital in our region. And what we started, we are going to divide it into three. What we had to do, we had to change our capacity, then manage patients and the staff as well. So capacity immediately, as we said, when we started getting more cases, all the operating theaters and normal operating was stopped. Of course, there was elective and non-elective and urgent operations were carried out in a different area. And the whole area was cordoned off and converted into an extended intensive care. So we went to nearly 3 times the capacity for patients who were ventilated. That means they were put to sleep and had the tube down and they were on the ventilator.
Right.
So our recovery room was also full, as well as the other theaters also had patients in it, in the anesthetic rooms where they put the patients to sleep and inside as well. So we were very, very busy. And then what we did was, for the patients, if you see, that these patients were very, very sick. They were on the ventilator, their oxygen levels would suddenly drop. There were varying ages of patients. There were young patients as well, because we had criteria for admission, but we had patients who were in their 40s and their 30s, 60s, everything. And these patients suddenly used to drop their oxygen levels. So one of the treatment plans is to put them on their tummy so as to improve their oxygenation. So you can imagine one person can't do it because they have to manage the head. We needed 6 people. So we had to train other staff as well to turn them. So we did that quite regularly. Loads of patients had to be done. Second thing is, these patients might have kidney failure. They presented with kidney failure or developed kidney failure during their stay, so they needed to be on dialysis. Some patients suddenly developed clots, and that if you read into the literature, they said that it is a disease of clots as well. So you've got DVTs or deep vein thrombosis, what you develop after a long flight, or clots in the lungs as well. So suddenly you used to have swollen arms or something, and because they used to be hypercoagulable. Okay, and one of the important symptoms is fever. But when we get it sort of what is called a cytokine storm, Dr. Mukul might explain it better, we used to get very high temperatures. And I've never seen temperatures of up to 44 degrees, that is 111 degrees Fahrenheit. Char tap, and what is akra. So that is
wow.
what we're looking at. And this is the thinking. And we used to see these patients. That means we have to put cooling blankets on them. We had to put ice on them, give them cool fluids. So this is how patients were. They were really, really sick. There was a mixture. Some were obese, some were not obese. But there were a mixture of patients. Now the staff, because we said nursing staff had to look after more patients, but we had got people from the operating theaters who came and helped. Our senior doctors' rota changed. We did more long shifts. There were tiring shifts, as well as the junior doctors' rota also changed. And they also did on and off like long shifts. But nobody complained. Not one of them moaned. Not my trainees and all were very good. None of the senior doctors moaned as well. We all came, we all did our shifts. They were long, tiring shifts, but we did it because we were in it together. Sometimes we used to put on the music inside and dance in our PPs just to keep the mood going. Remember that as senior people, we have to support our staff,
Right.
our trainees, and the other staff coming from elsewhere because they are looking after more patients. It was an unknown thing. We didn't know what was going to happen.
Right.
It was an overwhelming emotional feeling when we used to lose patients suddenly. And it is not only me, I discussed with people all over the world. They have the same feeling. Oh my God, they're going off, they're dying,
Right.
have done something. These feelings always happen. And then you blame yourself because if something goes wrong, however senior you are, the more senior you are, you say, oh, you start blaming ourselves. And then afterwards, we used to get breaks. We used to discuss our patients during breaks, and we had more consultants on so that we don't feel left alone while while having major decisions or anything. So it was very good in that time. We were pampered in the sense we got some food given by the hospital. They used to keep some frozen food in the freezer and we could take out and eat. We were given, the community stood for us, as well as they used to provide us with food or creams or things like that. Just small things which kept us going. And thank you very much to the community as well. When we used to come home, we were very tired. We had to be very careful because there was always will I get infected? Will I get infected or will I be asymptomatic and transmit the infection to people at home?
Right.
Yeah.
Right.
When I used to come home, I used to take a shower before leaving the hospital, go straight into the bathroom, have a shower again, clothes washed for washing, and social distancing
Absolutely.
at home.
Oh my God.
Right?
Right.
So it used to be, and then again next day, and sometimes very difficult to sleep. For nearly a month, I could not sleep well. You keep thinking about it, your eyes wide awake, and you sleep, and then again within 15-20 minutes, you suddenly get up. Nightmares. So these, you have got an institute, so you know what people go through.
Right.
And I am just thinking that in the days to come or in the months to come, we are going to possibly see a lot of PTSD, and things. We used to come back with headaches, as we said, because of the masks and because of wearing PPEs and things like that, and mental stress. And post-traumatic stress disorder is going to be, I think, quite rampant more amongst the medical and nursing staff because of what they have seen, and probably just scared whether there's going to be a second wave. And we were just discussing with, sometime that, there's supposed to be a second wave this week or something. It's not yet happened. We're just keeping our fingers crossed, and I'm keeping my fingers crossed for all of us that we don't have a second wave, because we want to come back towards normality.
Absolutely. Absolutely.
Yeah.
Wow, that was intense, but I don't know how you guys have been going through this. It's phenomenal. Speaking of normality, then what according to you would be the new normal? What do you think?
Near normal. It's very uncertain, or the new normal is very uncertain, because is COVID-19 going to stay? Probably yes. When we were medical students, around when I was in the second or third year, we had HIV come, and the whole world was really scared that we are all going to die. It's not, I know it's a sexually transmitted disease, but it was transmitted through blood transfusions as well. So Mukul will nod his head and say yes, because we were scared that it is going to destroy the world. Then SARS came and we said it's going to destroy the world. Lots of uncertainty, but if we are a team, we may be able to overcome it. More people working from home, all the admin staff possibly working from home, possibly cleaner working conditions, that they'll clean more often, more personal hygiene, and calmer roads, possibly more natural habitat. And one more thing which will happen in hospitals, maybe people might be scared to come into hospitals because every cough or cold will be first. If anybody sneezes, previously we used to say bless you in this country. Now they're not going to bless anybody. They're going to look at us and say, oh my God,
Yeah.
is it going to be COVID? So the first thing,
Right.
we're forgetting that normal ailments occur. Normal flu, normal cold and cough, normal diarrhea will
Right.
occur. But we are always going to say, oh, is it COVID? And we
Right.
cannot ignore the other diseases which are going to happen. The
Right.
new
Right.
normal is uncertain, depends on whether the second wave is going to come as well.
All right.
What do
All
you think,
right.
Dr. Acharya? Is that correct, what I'm saying?
Yeah, I mean that's quite well put. If I know we are going to wind up now, but just add a few things quickly, if that's all right. What Nandita described is absolutely correct, and I do sort of agree. Uh, what is happening is, I think, um, social distancing is going to be becoming a norm. I know we human beings are very social animal, and we like to meet our family and friends and be together, shake hands, and give each other a hug. But I think that probably is changing. We are rediscovering ourselves is what is happening. Hand hygiene, is going to be playing a huge role. We probably will see designer masks, from Gucci and probably all the other, fashion houses coming in, and that probably would probably become a norm, of the entire concept of travel is going to change. A lot of and it's itch which bites, which everyone travel. Uh, it's not travel you must, it's travel if you must. What was the original saying, but it did change to travel you must. And then everyone was seen globetrotting and visiting exotic places. Of course, the travel industry, which is a huge industry, which keeps the economy going, is obviously going to be badly hit. But then people will rediscover new ways of traveling, maintaining distance, probably a less number of passengers in a flight, in a train, or in a bus, and that is what is going to happen, which probably effectively give us more time to spend with our family members. you know we'll all are going to rediscover family values, family bonds. So very ironically, and if I may say, that in addition to slowing down to care for ourselves, I think Mother Nature is also healing while we have been isolating. Now, it's a huge speculation, but I wonder if this COVID-19 might be what, was actually required for the planet to reverse some of the climate changes and the climatic damage which had happened. And and we hope that as the pandemic eventually ends, and we sort of, very gradually resume our regular routine, we'll reevaluate our formal normal and probably rediscover a new normal. So this probably is an event in history for all of us, which is going to stay lifelong, and we probably are going to tell it to our second and third generation, that how life changed culturally,
Right.
economically. So we would realize that we have to treat not only us but our planet with with a lot of care and a lot of respect. We realize how fragile life is, and recognize that everything can change in a moment. One mutation of a virus, a small
Yeah.
RNA, electronic microscopic virus, can change the entire planet. So just
Right.
just just think about it. So what are we human beings? Just a small speck on this huge scheme of things, created. We don't know who's created that, but a small virus can literally shut down the world, and we could not have prevented it. We don't know how it happened. There are a lot of theories, you know but as I said, wearing mask, hand hygiene, maintaining social distance, office work, as Dr. Nandita has pointed out, a lot of us would work from home. But then are the number of patients going to visit hospitals going to be less? No. I've already started seeing a lot of other infections taking over. I've already started seeing all other non-COVID-19 patients come back to the hospital. The fear is receding, and they are. So during the peak of COVID-19 season, there are a lot of patients who were at home unaffected and didn't want to come to the hospital. It's all changed now. They're all coming back to the hospital. So
Yeah. Our non-COVID wards are very busy. Non-COVID intensive care is very busy. One small point I wanted to add is our namaste and Hath Pai Dhua is very important. That I think we have to go back to the basics. And we have actually, when during the pandemic, in our intensive care, quite a few people did namaste. So I said, there you go. We've gone back to our Indian basics. I'm very happy with that. But
right.
and hand hygiene, and wash yourself all the time is very
right.
It all depends on the immunity which we are going to develop, whether it's going to be lasting for months or weeks or years, and that would define whether we're going to have a second surge or not. Let's be optimistic. Let's sort of think that we've already got something called as herd immunity, and herd immunity means that when in a given area more than 60% of the population is exposed to the disease and produces antibodies, either by exposure to the disease or by a vaccine, then they would stop transmitting that disease to all those who have not been exposed, because the chain is broken.
Right.
So the lockdown has to ease at some point, a gradual phase out of the lockdown. Let the youngsters mix with each other, with obviously a certain distance, and just protect the vulnerable and the adults.
Right.
That is probably what is going to happen. So let's hope that herd immunity, which is more than 60% of the population being affected and producing immunity, would happen.
Right. Thank you so much for these valuable insights. You've already given us so much to go with. As medical professionals, both of you who've been in the thick of this pandemic, is there anything else that you would want to say to people globally? Is there anything that you would want to add?
The only thing that is certain in life is uncertainty.
Oh, yeah. Yeah.
Okay, change is always a norm of life, the norm of this planet. See, diseases have come and gone. As Dr. Nandita said, HIV came and we're all worried, scared that this is going to wipe us out. People probably thought the same thing about 400, 500 years ago when they were hit with plague, and then the flu, the Spanish flu. Yet, we have survived. The human race, the rest of the world will survive. The planet knows how to take care of itself.
Yeah.
The planet knows how to heal itself.
Right.
And I'm not sort of, instilling a false sense of security, but I would want to think that we would eventually find this together, ironically maintaining a distance, though together.
Right.
And we would obviously, and the body will obviously learn ways of protecting itself, as long as we are sensible and we maintain a social distance and not get carried away, use a simple infection prevention control precautions, and learn to adapt to the new way of life. I think there is still definitely hope. It's not the end of the tunnel. It's not the end of the world. And life will go on,
Right.
And I'm sure.
I have one message. It's important to look after yourself, look after your own health, because then you'll make yourself more susceptible to other illnesses like diabetes, good control of blood sugar, high blood pressure, good hand hygiene. And one important message, like doctors and nursing staff are all humans. We are all humans. We are not God. This is an unknown, strange entity. And we are fighting hard. We have put our lives at risk, as well as kept patients ahead of our own families. We are fighting hard. So all of you, public, be with us, because that will improve our morale and give us more strength to fight for our patients. And that's a gentle request to all. I keep saying, just clapping is not enough. We need your moral support.
Absolutely.
All the doctors and nurses and everybody say that thing. We need everybody.
Yes.
And we will overcome this.
Right.
Okay.
Oh yes, we will.
We will. Yes. Yeah.
Thank you very much.
Thank you
very much.
Thank you.
Yeah.
It was a pleasure, and you two have been extremely good in sort of conducting this.
Thank you.
Thank you so much.
It was very, very useful.
Yeah, it was an honor to get these insights from you all, and thank you for choosing SAMAKSH-SoulWaters for doing this.
Yes, thank you very
much. This is really going to help everybody.
Thanks.
Thank you.
We can be of
Thank you.
community.
Yes.
We will do so.
Yes. Thank you very much.
Thank you for your
Okay.
time. Thank you.
Cheers.
Thank you.
Thank you.